follow the case, and if it didn't heal, then we'll have to perform a periapical surgery. Now, looking at the soft tissue of this young girl, soft tissue was, perfect, perfect color, contour, architecture. But when you take a scan, you will see there is two huge buccal perforations on tooth number 7 and tooth number 8. Now, the last thing you want really as a clinician is to be on the defense and to, after you go in and you tell the patient that I did not perform the perforations, they were there before. I mean, there's no way to prove it with PAs. Now, also, the conversation changed for the treatment plan, and this exactly fits the studies, the article that I just shared with you, and other studies by Patel, et al. As well, that your diagnosis is incorrect 60% of the time, and your treatment plan changes over 50% of the time. So now we're talking about perforation repair, possible forced eruption, aesthetic, gingival recession, cost, time. The conversation has completely changed. So this case was treated, and what you're going to be seeing through my presentation is long follow-ups, because I do believe that it's a testament for time and that these procedures either work or does not work. And of course, this procedure was handled in a both non-surgical and surgical approach, and the patient healed very well. So what do I mean by a new understanding of the dynamics of endodontic pathology and disease and healing? For long time, I used to base my outcome on periodontal probing. Now, I don't want to be, misunderstood that periodontal probing is not important. It's definitely very, very important. But again, we always looked at disease in 2 dimensions. And now we're looking at 3 dimensions, and we're looking at healing in 3 dimensions. So as we're going to see in our new understanding, we are approaching cases that are probing very, very differently. So now I really don't determine the outcome of a case based on periodontal probing. Why would a case like that, with probing depth 360 degrees all around the tooth, has a much better prognosis, I would say excellent prognosis, compared to a tooth like that, which has a decent root canal treatment and just a periapical pathology and no probing whatsoever? Again, this is the new thing I'm telling you about is, and we'll go through these cases together, and we'll see how this different understanding of the disease in 3D led to a completely different approach for treatment. What I'll be talking about in this presentation a lot is patterns of recognition. That's what I talked to you in the beginning of my presentation when I went back to these cases and I start seeing patterns, why these cases were healing and why cases failed. And that's where all my learning experience came from. So I'm not going to show you only one case, and we can go, through half the day showing you cases like that. Why are cases like that are probing all the way down to the apex, either in one location, 2 or 3 locations, or 360 degrees? When I see them now with a different understanding, I tell these patients, you have an excellent prognosis for these cases. So what I've been doing with Dr. Bruno Azevedo and the University of Louisville, we're looking at these cases. We're taking a pre-op scan, we perform the root canal therapy, and then after, this is like 6-month recall, still we're getting some healing there. I mean, but again, great healing. And then what Bruno does is that he has a software where he can actually overlaps the pre-op and post-op. And by doing that, we have a 3D evaluation and understanding of how the disease has developed, how the disease is in 3D, how the size of the defect is. And when we superimpose the pre-op and post-op, we can actually see in real time the patterns of bone growth, the trabeculation, and how these lesions do heal. So when we start getting cases like that now, this is whether it's a initial treatment or a retreatment, and we see cases that are probing, and we see that a lot. Now we understand that every time we have a root that in the middle of a mandible or a maxilla, and we have a very thick cortical plate, it is very, very challenging for this lesion to break through these thick cortical plates. And what it will do, it will just break through the cancellous bone and give us these big lesions probing to the apex. You get also a buccal or lingual buccal expansion or lingual cortical plate expansion. That's the way, this is the easiest way for the infection to get released. And after performing root canal treatment, these patterns of bone loss heals extremely well. You get the cortical plates healing back, as we see here. And if you compare it here to here, and these are the patients that present to you with the second molar with probing depth all the way down to the apex, and you get this, the gingiva is really swollen and puffy. These are the cases that I'm sharing with you here, and you get the reconstitution of the buccal cortical plate, and everything heals very well. Let's take this to a different extreme. A case that if these teeth were extracted, it would have cost the patient a lot of money and time. So now with our different understanding, we're doing a better diagnosis, better case selection, a better predictive outcome. So this case had a premolar, as we see here, a bridge, a 3-unit bridge from a premolar to the second molar. And if this is the second molar that I showed you earlier, that it's probing almost 360 degrees around the tooth. Now, we're going to talk later on about patterns of bone loss regarding marginal ridge cracks and vertical root fracture. And again, this pattern does not fit what I'm going to share with you later. So now, even this case is probing 360 degrees, the second molar. You go ahead now understanding how this disease developed in these particular cases, and you do the root canal. These cases heal very well. Now, in these two previous cases, we have to understand that, I use the, traditional irrigation methods, I use EDTA, sodium hypochlorite, chlorhexidine, and sometimes we use, we tend to get impressed with some of these fancy 100,000, irrigation systems, but we have to understand the basics, the biology, that, we are not really sterilizing canals. What we're doing is we're just reducing the bacterial load to a level that will allow the body to take over and to cause healing. So as we see here, these cases do heal very well by really understanding in how these cases do heal and how these specific cases presents itself when there's a very thick cortical plate of bone. One of the great things, now we'll switch gears here, is with 3D imaging, with applying that to the EVOL DX, is to have specific filters, like I mentioned earlier, for anatomy. So if we're looking for anatomy, we can actually see that, this tooth has, this is an upper molar, we have 2 canals here, and actually look at the anatomy and the clarity of there's 2 distal buccals and 1 palatal canal here. And now when we go in, I know there's also going to be an isthmus here in this area there. And then when we fill or obturate these cases, it's a replica, it's a copy of what we're doing and what we're seeing in 3D. So it's actually enhancing visualization. We can take measurements, we can see where all the canals are, and we can approach that and treat these cases very, very successfully. So in cases like that, that's a canine. And when we see, like we used to believe that when there's a J-type lesion or a lateral lesion, sometimes we're not sure whether it's a lateral canal or not. So let's go through this case together and share with you how can, when you import these DICOM images into EVOL DX, we can actually see the lateral canal and we can determine where the location of it. So this is basically a realistic rendering, task realistic rendering for the DICOM images that we had. And then what you see here,
so check it
I just want to put the volume down. And what we see here is all the filters that we have for maxillary sinus to check vascularization, for cracked teeth, for anatomy. So now this is the very high resolution, and you can actually see, I will just change something here. And actually you can see the lateral canal here. And actually, we will be able to see it here as well, here as we see here. And we'll be able to zoom in and out and to see where it is. And when we go here, you will actually as well see it. And we can exactly locate the location of the canal. So when we go ahead and obturate this case, and there was definitely an overextension of BC sealer here. But again, when we compare that to the post-op, look at the complexity of the canal that we have and how it really reflects what we were seeing in the EVOL DX anatomy. And that's a 1-year recall showing the complete resolution almost of the lateral lesion compared to here what we started with. And actually, as we see here, where the axis of where the sealer is coming out of the lateral, this was the location of the lateral canal as we see it here as well. And as we see it here as well. So again, you know, applying this technology can help us a lot when we're doing, when we're talking in the second presentation, when we're doing selective retreatments and being able to guide to find certain canals by applying realistic rendering. So the next part I'll be talking about is cracked teeth, and I'm sure this is a challenge for all of us as clinicians. So the AE in 2008 came out with a colleague of excellence talking about the different types of cracks. And basically what they determined is that for a tooth to be treatable or not is really based on the relationship of the external extent of the crack in relation to the CEJ. And us as clinicians and endodontists, we never evaluate that from the external aspect. As endodontists for years, what we've been doing is actually opening, accessing the teeth and applying, you know, methylene blue, using the microscope, sending these beautiful pictures to our referring guys and telling them how far the crack has extended and whether these teeth should be salvageable or not. So what I want to gonna do in the next 10, 15 minutes here is to show you the evolution that in my practice and where this is going with 3D imaging, with EVOL software, from the traditional way that we were staining teeth, spending time, and sometimes the tooth is cracked that has to come out after we spend half an hour or 45 minutes on it, or you know, it's savable. Based when we were basing our decision on the internal extent, the tooth is considered to be extracted. And if it did not go through the pulpal chamber or any of the canals, then the tooth is rendered to be successful. Now, the next step that, you know, the evolution that we're using now in our practice, and actually we're putting this for a publication, is now without even accessing the tooth, with certain patterns of recognition, and comparing that to CBCT, without accessing the tooth, we will be able to determine the exact extent of the crack and its relationship to the CJ. So we've been using that for the past few years. Now, recently in the last year, with using EVOL DX, we are, as we're going to see, that we are actually able to visualize the crack on the DICOM images by the increased dynamic range, applying task-specific rendering filters, and we are actually able to see the crack. Now, what I'm going to do here for a second is I'm going to enlarge. I'm going to go back here. Just I just want to share with you something here. I want you to see how small this crack is. To be able to visualize that crack on a DICOM image here is just a mind-blowing. So really pushing the envelope of imaging. So, you know, it's just a great way to communicate with the referring dentist. And the question has always been that, is there a correlation really between the crack inside the tooth and outside the tooth? So if I see a crack that's inside the tooth that didn't get into the distal canal, does that mean that from the outside it did not go below the CEJ? And we will have an answer to that in the presentation. So now actually, for the first time, by just looking at the scan and following certain patterns of recognition, we will be able, without even axing the tooth, we will be able to determine how far the crack has extended in relationship to the CJ, and to make the correct decision and treatment plan for the patient, whether to save the tooth or to be extracted. And again, this is through patterns of recognition. A beautiful example for that is this patient, teeth, the second molar, lower left second molar and first molar were referred. Both had marginal ridge cracks. And as we're going to see, tooth number 18 will be extracted, and tooth number 19, or the first molar, will be saved. So if we go through the scan here, and I'll try to go a little faster here, we will see a certain pattern of recognition on the distal. And I will stop. So this is how we navigate the scan. As we see on the mesial and distal of the first molar, the bone hasn't changed. But if you see here, there's a little V-shaped defect. Of course, there's a pathology there. And I'm going to stop the video in one spot here, go further down. We're going to go down, down, down further. Okay, I'm going to stop here. And so now I am actually below the CJ, okay? And we still see this little half circle there. This is an indication that the fracture has extended below the CJ. And then compared to the first molar, the level of bone on the mesial and the distal is intact. So actually tooth number 18 was cracked. We took it out. And when we do the measurements, you will see that the V-shaped defect, was very strong correlation with the extent of the crack below the CJ. Now, we did not jump in and start taking teeth out. This was actually after we've flapped, hundreds of these teeth, confirmed that this pattern coincides with a marginal ridge crack that extends below the CJ. Not only that, but we also did measurements, and the measurements also, there was a very strong correlation with the V-shaped defect and how the crack, far the crack extended below the CJ. So this is number 19, or the second molar. And again, as we see here, the marginal bone, we don't have this V-shaped defect that was noted on the second molar. This patient came in a few months later to do the root canal. And as we see here, definitely there's a marginal ridge crack that goes all the way down. But again, it was not extended below the CEJ based on the analysis of the DICOM images. And this is the healing, I believe, after a year. Another case presents to us with pain in the first molar. Definitely this patient needs a root canal, but again, applying this pattern of recognition now, and now our eyes are trained to see different things that we never looked at the scan. Now we can see that this patient is coming actually in for, and actually the symptoms were from the second molars, and it was not probing. It was like 4 or 5 millimeters probing on the distal. And I think most of us would have, before that, would have jumped in and performed the root canal. And then a few years later, this tooth would come back with more breakdown in the attachment. And this is after the tooth has been extracted. And you can see very clearly that, even with the crown there, we were able to determine the patterns of bone loss on the distal of that tooth, indicating that how far the crack has extended below the CJ. So in our study that we did at UIC, we found that there's a very poor correlation between the internal and the external marginal ridge cracks. In 75% of the teeth, where the internal marginal ridge cracks did not go anywhere, 75% of the time, these cracks have passed the CJ from the outside. An example of that is a patient that came to our office on a Friday. And she was flying to London that day, and she presented the marginal ridge crack, as we see here. And we knew that, looking at the DICOM images, that this tooth has to be extracted, but we didn't want to do the extraction because she was, flying. So what we did is a pulpectomy, emergency treatment, and when the patient came back in, we told her that the tooth had to be extracted. So again, this confirms our study. Among other teeth, we had 200 teeth in that study, that the marginal ridge crack, although did not cross the chamber floor or get into the distal, any of the distal buccal canal or palatal canal, there was no correlation between that and that it's extended below the CEJ as we see here. So why is this important? This is important because you get cases like that when it's sent for evaluation of, it's a first molar for evaluation of treatment of the distal buccal root. You see there's distal buccal root resorption. And again, put this into the article I shared with you in the beginning, diagnosis and treatment planning. We would jump in and extract this tooth or do a root amputation for that tooth. But if we go through the scan, you will see here that there's nothing wrong with the distal buccal root. Actually, the defect is all coming from the mesiobuccal root of the second molar. And we can tell that from the V-shaped defect that we're seeing here, the base and the apex of the defect. So, and what actually we're having here is a crack of mesial marginal ridge crack of the second molar and not the first molar. Again, incorrect diagnosis and changing in treatment planning. And you've seen now that, being demonstrated in several of the cases that I presented to you today. So now, applying the realistic rendering and Evol DX, we don't even have to access the tooth. We can see that, we see how it extends, and these are the reports that we're sending to our referring dentists, which really helps the patient rather than going through unnecessary treatments. So let's go through an Evol DX. This is a case, again, that was extracted. And as we see here, there was a marginal ridge crack that extended below the CJ. But going through the DICOM images, and now, because prior to that, Evol DX technology and applying the filters that we see on the right here, there was no way we were able to visualize marginal ridge cracks. You can see the crack going from the mesial to the distal. You can see it actually here as well. I'll go through that quickly, so I won't be losing much time. Here, you can see very, very clearly here, and the distal marginal ridge crack here going below the CJ. And applying also their realistic rendering, you will actually, it's amazing, and this is like, basically they call it AI, which is artificial intelligence, where applying these specific rendering filters, you can actually visualize. I'm not sure if it's clear or not in what you're seeing, but you can definitely see it all the way here, and it goes and stops at the area which exactly fits the extracted tooth that I shared with you earlier. Now, not only it will allow us 3D imaging to visualize, marginal ridge cracks, but also if this tooth is treatable or not. We see a lot of patients that has cuspal fractures. What I do is I put a little any object there to separate the cusps, and we take a scan. And with the scan, it actually, with the scan, going through that scan, we can actually visualize how far the cuspal fracture is and its relationship to the crestal bone, and if this will need any crown lengthening, if it's subcrestal, if the tooth could be saved in a restorative fashion, or the tooth will have to be extracted and an implant has to be placed. So all this information we can share with the patient, we can share with the referring dentist. You can crop the image, exactly look, where the fracture is. So very, very valuable information that can be providing us to see and treat these type of cases. And what I usually do, I don't pull the cusp out. I used to do this mistake a long time ago, but you're actually setting the stage for a lot of problems. You get a bleeding, it's hard to temporize the case. You're always gonna have a tissue that's very inflamed, which will be very challenging when taking impressions. So I just, use a certain clamp, perform the root canal treatment, do bonding, and then it's sent back to the GP to prep it for a crown. And even if this piece comes up later, you have healthy tissue at that time to take your impressions and temporization. The next step is vertical root fracture. We published an article in 2012 with what are the 5 findings that if you see in a DICOM image, it's an indication of a vertical root fracture. And one of these criteria was the expansion of any of the buccal cortical plates. These cases, in the early stages, they do not probe. So a case like that, that's not responding to treatment, this is the mesial root of a first molar. And as we see here, this is the lingual plate, and this is the space that exists between the lingual plate and the mesial root. Now, if we see that in a 2-dimensional X-ray, we can either go and do a non-surgical retreatment, or we can go ahead and do an apico. But what we're having here, as we're going to see, is we're having a vertical root fracture. So you can miss that if you did a non-surgical retreatment, or you're going to miss it if you do even an apicoectomy there. But again, understanding these patterns, that with these type of patterns of bone loss, it is a case of a vertical root fracture. So this was prior to applying EvolDX. Now let's see, when we apply this case to EvolDX and see how can we really visualize the crack. We can actually, by applying the dynamic range and increasing the dynamic range in cases like that, and applying the realistic filters, we can actually visualize the crack on the lingual aspects, as we're going to see here. So this is the filter that's applied for the crack for vertical root fractures. And I'm just going through the scan here, and we'll see here that is going to show up now when we're moving. Very clearly, you're going to see it here, which exactly corresponds to the vertical root fracture that is on the lingual aspect of the mesial root of the first molar. This is really outstanding to be able to not confirm it just only with the patterns of bone loss that we used to do prior to the EvolDX software, but now actually to be able to visualize it, explain to the patient why this tooth has to be extracted and why an implant is indicated in this case. Again, this is really pushing the envelope for cases like that. So in the next maybe 10 minutes or so, we'll just touch on invasive cervical resorption, because again, with 3D imaging, we are able to diagnose these cases, treatment plan these cases differently. So if you would take, I'm not going to get into all the predisposing factors, and it's a completely separate presentation, but these cases really do present to us and the patient with a lot of challenges, especially when it comes into the aesthetic zone. And I will share with you, a couple of challenging cases and how we approach that in our practice. Of course, we have the classical Heather-Sayes classification 1 to 4. That's how we communicate with our referring dentists about the different type of resorptive defects. Dr. Shannon Patel has also a great article talking about the different types, the different classification in 3D of resorptive defect, which is really amazing. But just this little video from one of the articles just gave us an idea about resorptive defects and how they are really complicated and how they attack a tooth. We always have a portal of entry. There will always be a protective sheath around the pulp. So most of these cases, the pulp is not involved early on in stages. So they would attack the dentin, but the pulp, as we're going to see here, this is the reparative sheath that will always protect the pulp. And I would say 90, maybe 95% of these cases, they are asymptomatic. If I would give you one tip in this presentation, is that most of the time when a patient comes in with a resorptive defect, the majority of the time they have more than one. And I would recommend that if you're taking a limited field of view, expand to a much bigger field of view. So this patient actually came in here to evaluate and treat a resorptive defect that was on the first molar, as we're going to see here. And as we're going to go through this scan, you will see that this patient has numerous resorptive defects. As one, there's one. Some of them are class 4, some of them are class 3, some are class 2, and some of them are class 1s. And as we're going to show you later on in the treatment, you will see some of them, depending, of course, on the classification, it will involve either just restorative procedure. Some of them would require a root canal treatment and a surgical procedure. Some of them will just, will have to be extracted, or just watch it, when it's really a very, very aggressive, a class 4. So in this case, the patient had upper and lower resorptive defect. I can't remember. I think they were like 11 teeth, as we see here. So this was like basically 1. So this was a class 3, class 1 or 2, we didn't need root canal, and then this is a 3. So we had 1, 2, 3, 4, 5, 6, 7, 8, 9 resorptive defects. So really a surgical tip that I would recommend that when you get a patient with a one resorptive defect, expand your field of view, and you will be surprised how many times you'll pick more than one. So we go through, our concept here is to degranulate the lesion and to be able to repair it. Sometimes it will require some crown lengthening. This is after this teeth has been restored. So I'll share with you to end this presentation, a couple of challenging cases. We were taught for a long time, when we see a pink tooth like that it is an internal resorption. And now with 3D imaging, we know that these pink teeth or pink lesions are actually not an internal resorption, or it is an external resorption. So usually what we do is, patient's communication is very important. There's a lot of challenges with these cases. Aesthetics, looking at the tissue texture, biotype, papillae, the level of the marginal gingiva from canine to canine, the patient's smile, his lip line. All these factors are taken into consideration, especially in cases like that. When the lesion is huge, we have to exactly see where the buccal plate is, and the treatment is the same in all of these cases. Basically, is to go in after performing the root canal treatment, degranulate the lesion, carefully restore it with Gerastore. And the reason we use Gerastore, it is because the research have showed by Dragoo that it allows PDL attachments to the restorative material. This is after sutures has been removed. And basically this is taking you through the case, and this is a 2-year recall on this patient. Now, the patient got a little gingival recession here, but again, I think as an outcome for such a case like that, the patient is very happy. I even explained to the patient that with a little, he can actually improve that by maybe a little gingival recontouring here through laser or having veneers. But again, the patient is extremely happy. And if we go back and look at his smile line, this is like, if you tell the best joke and ask the patient to smile, this is the maximum smile that this patient can give us. So again, many things has to be taken into consideration when we are treating and treatment planning these cases. This case was actually a resorption and a perforation. And again, in these cases, we start using different materials. So we don't use the same material for every patient. So this case, we need to use some bone grafting, guided bone regeneration. We need to use also some growth factors like GEM21S, which is recombinant DBF, to enhance the periodontal regeneration of these cases. So this is the bone graft. I usually use Encore, which is 70% cortical, 30% cancellous, and it's mixed with GEM21S to enhance healing. Different types of membranes are used. You have to know the function of each membrane, how long each membrane. You want a longer resorption time for membranes that are at the when you're doing certain periodontal surgeries. So again, all is this put into consideration. That's the immediate post-op scan, and the patient has been with sutures, guide sutures. And with the beauty again with scans is that you can see here evaluate healing with bone grafts as well. So with healing, you will see that here there is no buccal plate, as you're going to see here. And when you look at the healing, you'll see that there will be a complete remodeling of the cortical plate here. And this is an 18-month recall. You know, beautiful outcome. Look at the papillae, no shrinkage, no probing, no bleeding to probing. And actually look at the realistic rendering with Evol DX. And you see here, remember here was the defect that we had here and we had here. So again, 3D imaging is a great tool to follow up healing and, you know, to share that with the patients. As I shared with you, with all these technologies, we are able to do a more, you know, complicated cases based on a better diagnosis and better treatment planning and better softwares like Evol DX and others that are going to be out soon into the market. So that actually ends my first presentation, and I'll be more than happy. I think I'm on time. I have 5 minutes like you guys requested, and I'll be more than happy to entertain any questions.
Thank you, Dr. Mohammed, for the very nice presentation with the perfect pictures and clear ideas about the new technology and the updated system that we got, as you said, like a few days ago. I would like to start with you some question, if you don't mind.
Sure.
Okay. For the first question from Dr. Fahad Al-Salih, he was saying, excellent and game changer. Thank you, doctor. Just to confirm, presence of pattern regardless regardless of probing?
Yes, I mean, I think probing was very helpful for us when we were using two-dimensional X-ray, but I think we were condemning a lot of teeth based on periodontal probing. And again, I'm not sending the message that we should not probe or probing is not important. I think it is extremely important. Again, it's a measure of the amount of bone loss, the type of defect that we have. But my point is that I wanted to make today is that now with 3D imaging, our understanding of how the disease is completely different when we're looking at comparing it to a two-dimensional image. Also, not only that, but also how it heals. I mean, I showed you cases that in the past, all these cases that were probing, you know, all around the tooth like that, I would tell the patient it's hopeless. But as far as we don't have the pattern to indicate that these cases are cracks with margin-rich cracks or vertical root fractures, this teeth actually has a very, very good chance to survive.
All right. And the second question was, what's your recommendation as the treatment protocol when a pocket of 4 millimeter crack detected clinically but not radiographically?
Well, let's put it this way. If there's a 4 millimeter, again, it depending on, there's a lot of variables here. It's a very tricky question because especially second molars, these are the teeth that are high, you know, with all the studies show that they are prevalence for cracks. Now, the tricky thing is with second molars that with third molars being extracted, sometimes you can get a pseudo pocket there because the tissue is really hyperplastic. So, you know, the measure of the attachment could be just at 3 millimeters. But again, it's not a matter of numbers, 4 or 5. You know, it's hard to condemn a tooth without knowing how far the crack has extended below the CJ, because if it's extended below the CJ, there's two factors here that will make this case, you know, just, you know, having poor prognosis. Number one, you cannot place crown margins to embrace diffraction, number one. Number two, as I showed in the case of the upper first molar, there is bacteria and biofilms in this crack, which is below the CJ, that will continue to cause periodontal breakdown. and break down in the periodontium, and we'll get more deeper and deeper pockets. So if there's no technology available with CBCT to determine how far it goes, you just have the discussion with the patient and just try to monitor it or try to do scaling and route planning for it.
All right. Thank you, doctor. Would you like to get like a 5-minute break, or you want us to start the next?
I can keep going.
Go ahead,
No
then.
problem. Tell me when.
You can start it now. Just give us a minute just to make sure that everything is ready.
Okay. Let me know. Okay.
I think we are fine. We are fine. If you are ready to continue, doctor, let's go.
Okay.
Okay.
All good.
I'll share my screen.
Okay.
Okay. Okay. Can you guys see my screen?
Yeah.
Okay. So the next part is, again, applying 3D imaging and how this technology is really changing how we are approaching cases in retreatment, which is non-surgical retreatment, cases that are not responding to treatment, and to surgery as well. So one of the recommendations, which is recommendation number 7 that is mentioned in the AE AOMR position joint statement, is that limited field of view CBCT is the imaging modality of choice when evaluating non-healing of a previous endodontic treatment to help determine the need for further treatment, such as non-surgical, surgical, or extraction. And that was also clear in the cases that I presented earlier today in the non-surgical part. So again, with 3D information and with EVOL software and using realistic rendering, we are performing now more conservative approach in accesses, as I'm not sure if Dr. Buchanan gave his lecture or not, contracted accesses or selective retreatments. So the philosophy that we have now, if you have a case that's presenting with a pathology and you can determine that the tooth has multi-roots and there's one root that's failing and the other roots really have no pathology. Prior to that, with two-dimensional x-rays, we're not really sure if there's a pathology or not. And we would go in the past, I would go in and deassemble an entire restoration, take posts out, silver cones or thermophils, and retreat every root in the tooth. Now with CBCT, we can follow and see if we have evaluate the other roots, see if there's no pathology, evaluate the lamina dura, evaluate the density, the length, and also only attack the root that has the problem. So we can do very precise measurements on CBCT to be able to have a very conservative and zoom in the source of the problem. In this case, there was a dissolingual separate root that was not addressed in the initial treatment. And after performing measurements on the crown, being able to see exactly where we're going to access and we go in, we can go ahead and do a very conservative approach that will allow us to go ahead and perform treatment on only the root that is not responding to treatments. And again, as I always promise you, I'll always show you follow-ups. And again, this is a 1-year recall, and we can see that the lesion has completely healed. So the question and some of the time that the discussion that I have with some of my colleagues is that, when I ask them, when we share, it's a little bit controversial in the endodontic community. And we asked them, they asked me, why do you do that? Why don't you go and they do the entire tooth? And I say, well, the other roots are fine. I said, a lot of clinicians want to take responsibility for the whole tooth. And then my question goes to them is that, okay, so how do you handling surgery? Do you go and do apical every root that is related to the tooth, whether it has pathology or not? And the question is no. And my other question is, why don't you want to take responsibility also? So there's really no difference between non-surgical and surgical, I believe. If the other roots are, I'm not saying if it's short or it's done below the standard of care, but if there's only all the other canals are treated well and this tooth had been there for several years, and there's no pathology, I don't think it is, it's not reasonable to go ahead and just retreat, the root that has the problem. Have a more conservative access, less iatrogenic error by taking posts out and fracturing crowns, and actually less cost for the patient too. And this, I'm sure this access will be much easier replaced. We all see fillings on CBCT as white. Now, what I'm going to share with you again with EvolDX and with heat mapping, we can tell exactly what's inside the tooth, whether it's a carrier, thermophil, or a separated instrument, which will actually determine what type of treatment we can do. Again, this is really pushing the envelope in diagnosis. In a case like that, which was already previously treated, we can, see whether we can do another apico, or let's go in and do another non-surgical retreatment. But by applying EvolDX, realistic rendering and increasing the dynamic range, as we see here, like we look in a scan, everything looks white. So what we're going to do is we're going to apply heat mapping and apply a realistic rendering filters, and let's see what is inside these canals. So anything that's gutta-percha is going to be yellow. Anything that's a carrier or a separated instrument is going to be in red. So by doing the heat mapping here, you will see very clearly that there is gutta-percha here, and there's also a carrier, so it's a thermophil. You will see it also on the other side. So this is a carrier with a thermophil. So whether you're going to go in and do a retreatment or not, you will know that you're going to be dealing with a carrier and a thermophil. But the exciting thing is that on the lateral incisor that's failing, which is this one here, it has a broken separated instrument. And the reason is that when you go up and down, when it's a carrier, you only see a circle when you're going up and down. When it is a separated instrument, as you're going to see here, when you're going up and down in the axial view, you will see this spiral rotating, which is the spirals of a file. So now, prior to performing non-surgical retreatment or surgery, you know that in the apical 1/3, there is a separated file by doing heat mapping, and it's surrounded with gutta-percha. So now we're decided to go with the surgery, and that's the separated instrument that was retrieved. And as you can see it here, that was retrieved. So again, this is the power of imaging. This is the information we're getting. We can actually change, the dynamic range, being able to apply certain filters, task-specific filters for certain procedure to determine carriers, broken instruments, thermophils, and being able to schedule the patient. I need an hour, I need a half an hour, I need 2 hours. I won't be, especially around curves, I won't be able to retrieve this instrument that's going around the curve. You don't want to be going and doing any non-surgical procedure, and then you're stuck because you cannot get to the last 2-3 millimeters because it's a broken instrument. So you can already change your treatment plan to a surgical approach from the get-go and save yourself time and be more efficient. Endodontic surgery has changed dramatically in the past 20 years with the introduction of great technology like microscopes, ultrasonics, piezo, new root and filling materials like MTA, bioceramic materials, has really changed the way we do apical surgery today. And if you look at articles that compared, this was a meta-analysis that compared traditional surgery with recent surgery, there is definitely a major improve in the success percentage of cases that were done that are done with new technologies. So what I'm going to share with you today is, again, applying this new technology. I'm not going to show easy cases that have a small lesion or so. I'll be sharing with you today our new understanding of healing of periapical surgery and how to handle cases that are close, very close, or in proximity, or actually inside vital structures. Also, when to apply bone grafts like infused GEM21S. Again, we don't apply them in every case. This is based on case selections. Piezo and Navident, or dynamic navigation, has been a tremendous help for us as clinicians, especially for clinicians that are performing periapical surgery in very, I would say, in areas where we're very close to vital structures like nerves, bundles, or going through a tremendous amount of bone, like drilling 10, 12 millimeters, like second molars and upper molars, second molars to reach the apex. So I'll share with you how these two technology has really impacted and made these procedures more efficient and much easier. So why surgical cases fail? It's either due to improper diagnosis, again, case selection, and treatment decision. Also technique. So diagnosis, for example, if you look at this two-dimensional X-ray, and again, it keeps coming up, comparing diagnosis and treatment decision based on the two-dimensional X-ray. Looks great, no pathology. I was actually impressed when the patient came in. The patient had symptoms with the lateral incisor, and I was impressed by the amalgam that was placed by the oral surgeon. And then you take a 3D scan, and the picture is completely different. You have a lesion. The amalgam is not even addressing the root canal system. So case selection and technique. Now, actually, this is, and I mean, I'm not embarrassed to show my failures. This case here is actually one of my failures early on when I was, performing, periapical surgery. I had a microscope, I had MTA, I had all the gadgets. So you can have all the technology that's available to you. With a poor technique, cases will not respond to treatment. And what happened here is that my resection did not include the lingual canal. Actually, this patient was brought back when, a few years later, and the resection was adjusted, and actually a retroprep addressing the lingual canal, mesolingual canal. And within 6 months, this patient healed very well. So technique is also very important. Now, when we evaluate surgical outcome, and that's what I mean by, again, how we evaluate 3D healing. We are in a time and age now that it's just, does not make sense to have outcome studies and evaluate healing in two-dimensional X-rays, as we've seen in my early part of the presentation and here as well. So we're conducting several studies evaluating surgical outcome. And what we're looking at, there's many factors that determine the outcome of surgical procedures. Blood clots, what anesthetic we're using, what hemostatic agents we're using is actually impacting the outcome of cases. So we are actually changing the 1-50. We haven't been using 1-50 for a long time. Again, the time is not sufficient enough to go through all these factors, but again, we are, and this also is being supported by a lot of studies in the perio literature and oral surgery and medical literature. The other factor is the defect type. There's been a lot of studies about the defect type, but there's never been a study looking at the buccal plate thickness, and that's what we're actually submitting for publication. We found that a buccal plate thickness of 1 millimeter or less will significantly have a negative effect on the healing. And again, this has the idea, we got this idea from the perio literature and wound healing literature in oral surgery, that cases with immediate implants or cases that has a buccal plate thickness of less than 1 millimeter has a poor outcome. And I'll share with you in several cases how we can handle cases that we're doing epicoectomy with buccal plate thickness less than 1 millimeter. Now, which is actually will have a different implications when to use grafting. We've spent a tremendous amount of time and money on investigating root resection and root end filling materials. And I think we did an amazing job, knowing that we need a 3 millimeter resection, 0 to 10 degree bevel, and we have great materials. But again, it's not only that that's impacting the surgical outcome. So this is an article from, von Arx, and these are his cases. And what really triggered me is that, as we see here, there is, when we do apicals, and these are all beautiful surgeries, why are we getting different types of healing? The buccal cortical plate hasn't formed completely here. Again, the beautiful resection, beautiful root and filling material. Here, this is a very simple procedure. I mean, no cracks, great bevel, nice filling, and again, it didn't heal. Here is not as perfect as the other two cases, but again, beautiful healing. Now, when I look at my cases, I have similar type of cases that either are healing or not healing. So this is, again, you compare to this to Dr. von Arx, again, the same thing. We're not getting completion of the buccal plate. Here's not healing. A premolar, which is a very straightforward case. Again, no healing whatsoever. And again, here with this extreme bevel, a more difficult case, you get complete healing. So what is, when I say patterns of recognition, evaluation of healing in the disease in 2D and 3D. So what all these cases have in difference is that the thickness of the cortical plate. And as we can see here, the thicker the cortical plate, the better healing we've got. So in the first one here, there is a decent thickness. Here, barely any thickness, and here, this is the thickest part. And again, with cases that I have on the lower arch, you can see definitely the same thing. When I talk to you about biofilms, we were able to create a specific realistic rendering filter for biofilms. And we were able to see that. And when we compare that when teeth were extracted. So talking about, again, buccal plate thickness and being able to determine if there's a biofilm or not, that can completely change the way we do things. So we are now paying actually more attention to if we can maintain the buccal plate thickness. So now with using 3D imaging, using the DICOM images, we can actually treatment plan to do a buccal plate window, as we're going to see here. And we can perform that with Navident or without Navident. But the whole idea is that you can get very accurate measurements. You can use a piezo, and you can, perform apical surgery, take the buccal plate out, as we're going to see here, have a beautiful access to the root resection. You see here the gutta percha, the isthmus in between, and you perform your procedure, and then you place back the buccal cortical plate. This CBCT was immediately after post-op surgery, and then we'll follow this up to, I do believe, 2 years or 3 years. This is 6-month recall. It's still remodeling, as we see here. And then this is basically, I do believe this was 3 years recall. And you can see here complete remodeling of the buccal cortical plate. So this is a way of maintaining the buccal cortical plate. How about if we're performing procedures that are in the sinus or close to the sinus, and you have to go through a tremendous amount of cortical bone to reach the apex? So in the past, when I'm doing a periapical surgery on a second molar, for example, and I have to go, or like a case like the previous one that I shared with you, and there's a very thick cortical plate, there's times that I have to stop the procedure and take a intraoperative scan to reorient myself in location to the apex. There's times that when the roots are very close to the sinus that I missed the root apex and I perforated the sinus. And I'm going to share with you, I think the next few cases, one of the cases is like that. So with dynamic navigation now, it's giving us actually real-time procedures. So what we do is we import the DICOM images to this technology. Again, this is an entire presentation about dynamic navigation. So I'm just giving you some highlights on the workflow of this technology. So the DICOM images of a case is imported into the Navident. Then you have to go through a certain workflow to basically calibrate the system. And that's the patient that was coming in for a discobuccal and mesobuccal epicoectomy that's close to the maxillary sinus and had huge torise, as you can see here. Now with torise, it's very challenging because the tissue is very thin. You have it's challenging when you're doing the reflection of the flap because the tissue is very thin. It's very easy to tear the tissue. So you have to be very careful and take your time when you're doing that. But again, with 3D imaging, you will be able to treatment plan that. So this is after the flap has been raised. And you can see how much bone I have to go through to reach the apex of the tooth. And this would have taken me, before using dynamic navigation, double the time, because I have to stop, take a scan, make sure I'm getting into the right direction. So this is again using the Evolve DX, the realistic rendering filter. And that's actually the procedure in real time. This is my drill here. And this will tell you how far am I from the root tip. So basically, I'm not looking at the screen. I'm not looking at the scope. This is basically the head tracker. The drill has also a tracker. It's like how do I call it? A navigation system. And basically, I'm looking at the screen. As you can see here, I'm not even looking here at the patient. What I'm doing is looking at the screen, and you'll see a couple of times that I'm reorienting my drill, and I'm away from the sinus here, and I'm just drilling, and you can see the number here is getting smaller and smaller, which tells me that I'm approaching the discobuccal root. I wanted to go for the furthest root first because this was actually the further into the bone, and then from that I can reorient myself. The lesion was big, so from there I can just orient myself and start going to the mesobuccal root, doing the enucleation of the lesion with piezoelectric, and that's actually after root resection and root end filling material with bioceramic sealer. A membrane was placed and it was sutured. This is the immediate post-op. You can see here there was definitely lesion perforated the sinus. There's some bone graft there, and this is the recall. So again, this technology and piezoelectric is very helpful for performing procedures that are very close to neural structures, like the mental nerve and inferior alveolar canal. So the next couple of cases are lesions that we're treatment planning and treating cases using piezoelectric surgery for lesions that are close proximity to the mental nerve. And actually, one of the cases will be a lesion inside the inferior alveolar canal. So let's see that. So this is how we treatment plan cases. I mean, again, this is all shared with the patient, talking about flap design, where we're going to do the flap, where is going to be the vertical releasing incision. We can have different functions on 3D rendering by doing also cropping. We can see the relation of the lesion in relation to where the floor of the lesion is. You can see there's root resorption here. This is the base of the lesion. So when we're curating the lesion, it's very, very possible that we can break into the groove of the inferior alveolar canal. So the most precise thing is to use in this case is to use piezoelectric. Piezoelectric is a great technology. It can cut through hard tissue, but it will not damage soft tissue. So even if you touch the nerve, it will not cause any damage. So there's different inserts with piezoelectric. There's inserts to perform the osteotomy, like in this insert here. There's inserts like it's like a saw that's marked. So again, the measurements are all performed with on the CBCT to know exactly the depth of the resection. It gives you great visibility. The water actually helps a lot in hemostasis. There's been several studies showing that the water implosion from the piezo would actually help with hemostasis. This is the one of the inserts. It's like a saw, and you will see later on there's like dots on it. So it's already pre-measured, knowing how far the resection will be. I'm doing here the resection of the root tip. I'll stop in the middle to show you that, how, again, with microscope and magnification, everything is visualized well. You're protecting, where you are. There's no guessing. And then we're just creating a space where we can just, tease this root tip out. And then we're going to use another insert. You don't want to go in there with curettes and start heavily curetting the lesion. So this is actually a great insert when we're creating lesions that are, and you see there the water is pushing all the granulation tissue out. Even if you touch the nerve, it will cause no damage to the nerve, and it creates hemostasis. So these really technology is very, very helpful when you're working in cases that are very close to maxillary sinuses or very close to vital structures like, the inferior alveolar canal or inferior alveolar nerve. That's another case, as we see here. Again, this is a two-dimensional X-ray showing a large area in relation to the mesial root. Attempt retreatment was done, and we couldn't actually get down any of the mesial canals. And as we're going to see here, this is the 3 distal canals in the distal root. Again, treatment planning with CBCT. You will know, again, this is one of the things you discuss with the patient, possible paresthesia. We know that, by the time when we're going here, there's definitely there is a perforation in the roof of the inferior alveolar canal. We're going to be dealing with inferior alveolar nerve. This is the 3D rendering showing the lesion, and you can see actually here the inferior alveolar nerve. Again, if you can visualize it as here. So this is after the resection has been performed with piezo. The enucleation of the lesion has been done with the same insert I showed earlier. And actually, this is the nerve here. This is the inferior alveolar canal. So again, if you can visualize that under magnification and you can, protect it, the patient, again, post-operative instruction with the patient, there will be, as far as it is not damaged, there will be a certain amount of paresthesia for could be a few weeks to a few months. But again, it's very important to bring the patient back, do face mapping with an explorer around the chin, around the lip, and then you also use, so you need to use an explorer for sharp pricking. You use also like a cotton swab for just light touch, and then endo ice to make sure that the temperatures, the patient can feel temperature, and then you have to just follow up with the patient. And again, this is from Mahmoud Turberjed's surgery book, and you can exactly, appreciate the anatomy here and how it's exactly what is presenting here in the osseous cavity of this patient. Again, no grafting was placed here because we didn't want to apply any pressure on the inferior alveolar nerve, only a membrane, good gut bleeding. And again, the thickness of the buccal plate here was thick enough that it does not require bone grafting. And then we followed this case, I think, for a significant amount of time. A 3-year recall, patients, had no symptoms, no paresthesia, and the tooth was saved, and the patient is doing well. So again, 3D imaging is very important when we're, treatment planning periapical lesions that are in close proximity. Show you actually cases that were actually in the maxillary sinus. One of the things that we have to evaluate with 3D imaging is the maxillary sinus septa, because by evaluating the maxillary sinus septa, these are the areas that will hold our membrane, collagen membranes, if a grafting guided bone regeneration procedure is indicated. As we see here, there's, these are the septa that we have to analyze. So when you're looking at a scan, again, you can see here that the roots are inside the sinus. We have to, this is the pathology there, and we have to really evaluate if there is any septa there to see if we're going to use any grafting, if indicated for any grafting, and if there is any septa that will, I'll show you actually more here in the 3D rendering. We'll see here that there is a little area there here. and here where, you know, if a membrane is to be used, it could be, in these cases, used. So in this case, definitely there was no septa. So this is actually the sinus membrane here. This after the resection. This is the granulation tissue. This is the apex with gutta percha. So we're performing a procedure. And then again, we had a good thickness of plate of bone. So all we need is just to put the membrane and follow that up. Now, this is a case I shared with you earlier. This was done many years ago, and I didn't have access to Navident. And while trying to attempt to do the epicoectomy, I was misdirected, and I did actually perforate the sinus mesial to the tooth. And we'll see that when we're doing the 3-year or 8-year follow-up on this case. You can see here, again, this is the membrane. You can see the vascularity of the sinus membrane, the blood vessels, which is very, very clear. This is a 1-year recall. Actually, bone filled in very nicely, as you can see here. And we'll go through, I believe, the scan in this case. And this is the realistic rendering and seeing the bone completely formed in at the apex of the tooth. Now, going through the scan, remember I told you I did, you know, misdirected, and that's why when you use navigation, again, you can see the hole here. Again, the bone fill. This is I believe, a 3-year recall. I'm just trying to change my, yeah. So when you see it going through the axial view, this is the area where I perforated. So I was a little off when I was going for the mesiobuccal root. And you can see it here clearly in the 3D rendering, and you can see it as well here. Again, it does not impact the outcome. We got nice bone fill, but again, we're looking at from the top. This is the perforation I had, but again, it's closed. There's no communication there. So the patient is doing well. So these are the things that could be avoided, you know, when we're performing periapical surgery. The root is, you know, as you see, is literally, you know, curved towards the mesials, and I was going straight forward here trying to locate the root tip. And actually the root was actually curved towards the mesial. And that's what happens with sinus perforation in this area there. This was a 5-year recall, actually. So how do you manage sinus communication? A lesion that's inside the sinus. So this is a case, it was a premolar. Again, evaluate. This case had septa in it. And actually the root was actually curved towards the mesial. And that's what happens with the sinus membrane, which is really not very ideal. So again, this is treatment planning, looking at in 3D all the angles of the defect. You know, if I'm sitting in the patient's sinus, you know, I want to see, you know, I'm only having one view, which is actually looking at the buccal when I'm performing the surgery. So I want to have a 3D mental image here from all different aspects, from 360 degrees of how this lesion looks like from the other side, how much bone do I have, how far the root is in the sinus, before going ahead and performing the procedure. Also, this follows the what post-operative instructions I'll be giving to the patient. Usually patients with sinus communication, there's a little nose bleeds after the surgical procedure. So this is something that has to be mentioned to the patient. Again, this is the granulation tissue inside the sinus, attempting to remove the granulation tissue. We have to be very careful, you know, because you don't want to push anything in the sinus. Again, this is basically draping the Zimmer membrane for the septum. You can see the patient actually breathing, and you can see the membrane moving. This is the bone graft being is one of my favorite, actually, grafting material. It's from Biomed Encore. It's 70% cortical bone, 30% cancellous bone. And then we'll have another, you know, a key thing when repositioning the flaps, that you don't want the flap to be under tension. You just, when you pull it down, you just has to sit down there without tension. Because if there is any tension there, it will definitely lead to resorption, further resorption of the bone graft. So what happens if we're dealing with cases where the roots are fenestrated outside the buccal plate of bone, or there's implants that are involved? So what we do is we do a wrap procedures. I do some, you know, implant case in the office, ridge augmentation, and this is an extreme example to show you how can we grow bone in cases that we're doing apicoectomy with. So this is a case that came in for preparing the site for an extraction of a molar here, and you know, this ridge to be having augmentation for a future implants placement. As we see here, there's a very like a sharp knife edge ridge. There's no way we can place an implant here unless we increase the thickness of this ridge at least another few millimeters. Again, this is all treatment plan. We see here how it is concave here. So we want to grow all this back with bone, as we're going to see. And we'll see now how with this procedure, which is called RAP, rapid acceleration phenomena, how we can apply it, the same thing with apicoectomy in cases that with implants that has fenestrated threads, or with case that I showed earlier with you that the buccal cortical plate is equal to or less than 1 millimeters. So again, this is the treatment planning for this case. This is the amount of bone we want to literally augment. And we'll go through the surgical procedure. Again, the mental nerve here is exposed and protected. It's very important. And let's go through the procedure. This is after the flap is reflected. And what we do is after the tooth has been extracted, and we start doing the wrap procedures. The wrap procedure basically include just several, like we can use a piezo, we can use a size 2 round burr, and what it includes is just perforation of the cortical plate into the cancellous bone, where you get bleeding from the cancellous bone to give all the growth factors, PGGF, or the you know, interleukins to the growth factor to help the augmentation and the adhesion of the blood supply of the grafting material to the bone. So we'll build the ridge as much as we planned. Sometimes we actually over augmented, because definitely there will be a certain amount of resorption. And again, when we put the flap back, it has to be under no tension whatsoever. So I'll just speed up in this video there, and I'll show you the re-entry and taking the membrane out and seeing how much bone we have accomplished here. Tremendous amount of bone here now that can support. So this is a titanium reinforced membrane, and you can see here the amount of bone on the ridge that we were able to augment and grow back. That is really sufficient for a placement of an implant compared to what we started with. So let's take this procedure and apply it for cases. This is the rapid acceleration phenomena. Basically, we're drilling holes into the trabecular bone to get blood supply to the graft site with all, you know, from the bone marrow to provide all the differentiated cells with all the PGGF, TGF, and osteogenic cells to the graft site to allow for improve the graft union to the bone, as I shared with you earlier. Now, why is this important in cases like that when we're doing periapical surgery? This was a case that was referred for 2 apicals, the mesiobuccal root of a first molar and the buccal root of a premolar. And as we see here that, you know, if you're doing a lot of surgery, periapical surgery, there is going to be times that you're going to be very close to or in proximity to implants. And you know, we should be able to handle cases like that. And there's any problems with the implant, we should be always able to act as well to correct that. In this case, it was very clear from the scan that when I flap the tooth, there's going to be fenestration of the threads and the threads will be exposed. Talking about buccal plate thickness now, we know that if we have 1 millimeter or less, these apicals will not heal. This is the buccal root of the premolar, and this is the mesiobuccal root of the first molar. So we will apply the same procedure I shared with you earlier, which is the wrap procedure. A semilunar flap was performed. Again, exactly what we know when we talked about adaptability versus predictability. Adaptability would be that with a two-dimensional X-ray, this would be a surprise and I have to adapt to it. With 3D imaging, it is now predictability. I know that when I raise this flap, these threads are going to be exposed and I have to do a wrap procedure. I know that the buccal plate thickness in both these teeth are less than 1 millimeter and I have to augment that as well. So what we do here is, again, there's no reason in this case because there was actually no to disinfect the implant. I'll show you another case where the implant was included in an infection, a periapical infection. And what do I usually utilize? The protocol to disinfect implants that are included in the periapical pathology. So a wrap procedure has been performed. This is after the bone graft is placed, covering the implant, building up the buccal cortical plate, and will go up to 3 years. And remember this picture here, where you have very thin buccal plate, separation of the implant, and you will see how much bone can we grow back on these roots and implant. And again, the same thing, a resorbable membrane was placed. This is an immediate, this is 12 months recall. This is not bone yet. This is still, it takes time. This is still part of the graft is still there, part of the graft is still there. The mesiobuccal root, actually, we got a nice cortical plate remodeling. And I'll just take you to the last recall we had. Sorry. This is here, the last recall we have. So we'll go, I like showing this case and I like showing actually in the recall with navigating through the scan. So this is the mesiobuccal root here. And look at the nice cortical plate we got there. Going through the implant, you remember this implant was, fenestrated. Look how much bone we got back on the threads of the implant. And then we're going to go to the mesial root, we're going to go to the buccal root of the premolar. And again, we'll see how much bone we got there. Again, nice thickness of bone there of the buccal cortical plate, actually more than what we started with. So, and this is actually another, I think this was a 3-year recall, going through the same thing through the implant. Nice bone here at the implant all the way up, no fenestration there, mesiobuccal root, cortical plates present. And then again, a nice bone on the implant. So we improved actually the quality of the bone on the implant as well as on the 2 roots where periapical surgery was performed. Another case, again, it's looking at the PA. This is the lateral, the upper left lateral and canine large lesion. How can you perform a surgery on a case like that when you don't know the extent of the lesion? Is it perforating the palatal or not? And again, so this is actually going through the case, and you can see the buccal plate is completely gone on, and you can see the 3D rendering, and you have to explain to the patient why we have to perform guided bone regeneration. These cases were unpredictable in the past. And you'd get these cases would heal with an apical scar, but now with all the technology that we have in diagnosis, treatment planning, and guided bone regeneration, we have a more predictable and a very predictable outcome for these cases. So this was an 8-year month recall. We'll just go to the, this is a 2-year recall. And again, look at the quality of the bone that we have. Look at the palatal bone formation. This is the axial view. And again, I like going through the scan. So I'm not only showing you a snapshot of any of the spatial views. You're going through the scans so you can appreciate the remodeling and the bone remodeling on each tooth. And the sagittal view, coronal view, sagittal view. You see the buccal plates, the lingual plate, complete bone remodeling in these cases. So, and again, this was, I think, a 3-year recall. So it is predictable to do these procedures, knowing how to use certain materials like GM21S. And research have showed that, in these cases, that in like the next couple of cases, we need more of a periodontal catalyst to improve the periodontal regeneration. With recombinant PDGF, like the GM21S, as you see here, it's a great chemotactic factor to cause chemotaxis for all the healing cells, to different unmesenchymal cells, to differentiate into osteoblasts, cementoblasts, and angioblasts to help with the healing. So in cases like that, this is the one I was mentioning to you earlier. When we have an implant that's infected in a lesion, so the patient presented to us, this is the upper left central incisor, this is the lateral. And when we see the clinical picture here, there was actually, see this, you can appreciate the size of the lesion, okay? So the implant is failing. They assumed it was failing, which was not. And again, the pathology is all coming in from the lateral incisor. This is how it presented itself clinically. All the swelling was actually on the upper central incisor, the left central incisor. You can see the swelling, the puffiness of the gum here. It was probing all the way down to the apex, 8 or 9 millimeter probing. And again, this is the defect after the flap has been reflected. So the pathology is coming from the lateral and creeping towards the implant. This is the resection of the lateral. This is the implant here. Again, this implant was actually disinfected with 2% chlorhexidine. Again, grafted, the bone graft was mixed with GEM21S, and a membrane has been placed. And this is an immediate post-op. Again, we'll go through, few years, a 2-year recall. This is the pre-op and this is the post-op. And what I'm going to do is I'm going to play them together, and we want to compare, the defect here and here. So this is the post-op, the 2-year post-op, and we're going to realign that and compare the post-op and pre-op. This actually, we are able to save the implant. This patient would have gone through extraction of the implant, extraction of the lateral incisor, and maybe ridge augmentation again, and then maybe 2 implants. So again, you see here beautiful bone formation on the lateral incisor, the implant. You see the amount of bone formation above the threads of the implant. Great bone remodeling for the buccal plate. And we were able to basically save the case. Now, when we have 2 implants next to each other, if tooth number 7 or this lateral was extracted, we know how challenging it is to place 2 implants aesthetically due to papillary shrinkage. Aesthetics is very, very hard to achieve placing 2 implants next to each other. So, cases like that, when we have, again, when we understand the disease and how it develops, and we understand the capabilities of the material that we have with guided bone regeneration, these cases could be done and saved very nicely. This is again applying GEM21S in conjunction with bone grafting, and you get complete remodeling of you have an endoperio defect. This is after the section, just the crypt prior to applying the graft material and the membranes. And that's aesthetically how it looks like. Beautiful gingival architecture, no papillary shrinkage, no gingival recession, and it was very successful. Cases that are calcified, as we see here, calcification. This is a first molar. There's endoperio involvement. There's furcation involvement. Again, with GEM21S and grafting techniques, we were able to regenerate, again, 2 membranes, 2 different types of membranes here. This one takes longer to resorb compared to this one. And again, you get very, very good outcome. This is immediate post-op, and again, this is later on. These are the immediate post-op, and you see here there's no bone yet on the buccal plate, and this is I believe a couple of years later, 2 years later, and you see again complete remodeling of the buccal plates. This was the mesial root, this is the distal root, and this is the sagittal view. And this is again furcation. There's no probing in the furcation, and the attachment is achieved back. So again, this will conclude my second presentation. Again, I would like to thank you so much for giving me the honor and the privilege to be part of the program. And again, I'm looking forward to hopefully meeting you all one day in person. And I'll be more than happy to entertain any questions that you have. Thank you.
Thank you so much, Dr. Muhammad. I do appreciate your efforts, your great cases and presentation. And I wish to ask you some questions, if you don't mind, before we close our day. So the first question was, which 3D criteria do you recommend to assess the healing of apical surgery? Is it pin criteria or chin criteria used by von Arx?
I think von Arx criteria is pretty, I like it actually in evaluating the healing. And I think for research, I think it is I like the von Arx criteria. But I mean, clinically, it's either working or not working, you know.
Well, I was going to ask you, do you have like your, let's say, your way of assessing, not following a clear guideline or a clear criteria for that?
Well, I strive for complete bone remodeling. Okay. I don't believe, I mean, there is a misunderstanding of apical scars. You only get apical scars if you're not, I have several cases that in the past, when you have to have a perforation through and through lesion and no bone grafting used, that's when you get an apical scar. But if you still have a pathology there and lesion did not heal completely, you have a low density area there, even if it's reduced in size, there is something still wrong there. Now, but I think it's something that maybe we should address, mention to the patient and follow up. I've entered in some of these cases again, and there was always something that had to be corrected, and the biopsy comes back as, granuloma or cyst, so yeah, I don't know. I think, if I don't see healing, then I would go in the case again and see, now I know why, certain cases were not healing. When you're talking about the buccal plate thickness, and I'm going into these cases, I'm not even changing my prep or anything. All I'm doing is the wrap, and I'm getting healing. So remodeling actually,
Right.
bone remodeling.
You mentioned at the beginning that you don't go back again if you see something, but let's say there is no sign or symptom. And then you say sometimes you get in and you think that there is something left behind. So what's the time, or what's your criteria to go back and open up?
So when we did the studies and we found that there was 1 millimeter thickness of the cortical plate, these are the cases that I was definitely getting in.
All right.
Okay. Definitely symptoms as well. If the patient has symptoms, then that definitely you go in.
Okay. The second question was, have you experienced any differences of post-surgical healed bone when regenerated comparison with non-regenerated?
I don't graft every case. So I don't think the healing should be any different. You're talking about post-operative, post-operative healing. Soft tissue, there's soft tissue healing and there's hard tissue healing. Soft tissue healing should not be any different. Regarding, if you have a good blood clot that you can, this is one of the things we're looking at when I mentioned we don't use 1:50, because it's in many textbooks that, when you're doing, molars, especially molar surgery or even anteriors, You know, some of the protocols, you go and give 1 to 50,000. You place, you know, epinephrine pellets. And as endodontists, we're notorious of loving taking pictures of crypt that is so dry, look like cadavers. And this has been shown in the medical literature and we are the only specialty that likes a dry field. I mean, completely. If you look at perio, they love bloody field because if you don't have bleeding into the crypt, you have, you know, osseointegration. If you extract a tooth and you don't have bleeding in the crypt, you get a dry socket. But, you know, we just notorious about, we have to have everything dry. So when I do my crypt management, again, this is, you know, again, I mean, I couldn't touch on everything as you can imagine. I don't make the crypt completely dry, just dry enough to be able to place my root and filling materials. And luckily enough, now we have materials that sets fast and can be introduced and, you know, placed fast. And also they are, you know, forgiving if there's any, you know, little contamination with blood. It won't impact like MTA and bioceramic series. We really won't impact their setting properties. And I have to create a lot of bleeding into the crypt, whether I'm using, you know, grafting material or not. There is several studies. I mean, again, I have these studies available that a lot of patients do have bleeding. There is, you know, why would you sometimes take a tooth out? Some patients develop dry socket. It's very common with wisdom teeth. Why? Because these specific patients have clotting problems. You know, they don't create a clot. The same thing when you're doing a periapical surgery, and these cases don't heal or don't heal well. So I haven't used 1 to 50 in I can't remember the last time I used it. And I try to create, and if there's no bleeding in the crypt, sometimes maybe we have to add some, you know, like what do you call it, plasma, you know, enriched fibrin or you know, any of, you know, the infuse to help growth factors to help with healing. We don't treat patients, they're all the same. We don't expect to do the same thing for every patient and they would heal the same. It's, you know, on an every case basis.
All right. Last question, if you don't mind.
Of course.
Do you service treat the implant before grafting?
I'm sorry?
Do you service treat the implant before grafting?
It depends. I showed 2 cases. One implant, there was no infection. It was when it was placed again in very thin bone probably, and then it just with occlusal force, the bone just got fenestrated and it was exposed, and there was an attachment there. So this was not infected, so we just don't do anything with it. The second case where I showed with the lateral and center implant, that was infected. And there's a couple of ways we can surface treat that. Actually, you can, you know, go with a burr and just, you know, trim a little bit of the surface out. And also, this is shown in the periodontal studies.